next part, which we want to discuss, medico-legal cases. There is a lot of dichotomy around the entire art of taking history. It's no longer a science, it's become an art, because there are different people, different education levels which we deal with, language barriers that we have both in the government, the private sectors, the corporate sectors. I think the entire complication of the scenario which is emerging today. It's there are different sexual orientations. There are different people are on different sort of drugs. There are so many things that we need to elicit. There is a third gender which is now legally required to be present in all your documentation. So eliciting history, social, medical, this is what we're going to discuss. And I'm going to invite Dr. Narayan Degaonkar on stage to please come up. Dr. Degaonkar hails from Nasik and is a member of the Board of Studies of the Maharashtrian State Physician Association and also president of the same body. Dr. Degaonkar, please come on board. And I'm also going to request Advocate Mayank Shirsagar to come on board, who is an advocate of the Supreme Court and associate at the Medical Legal Attorneys. Dr. Advocate Mayank Shirsagar. Ladies and gentlemen, please give them a round of applause. Dr. Degaonkar, you can give your keynote address. Request you to kindly restrict to 7 minutes. Thank you.
Good morning, friends. At the outset, I would like to thank organizers, particularly Mr. Vajpayee. He has called me here and given me the opportunity. Basically, the topics to be discussed today, actually in day-to-day practice, we come across so many medical problems at the same time, judiciary problem. I will not be surprised in the future. Even medical graduates will have to learn laws. And because the day-to-day, as we see, even 2 days back, we had a problem in Nasik, in one of the government hospitals run by corporation. This was manhandled by mob because of the death of the patient. It is so easy for the people, and they are coming. There are so many leaders. There are different social elements which are coming across and trying to harass the doctors at some or other time. As one of my friend, Dr. Shankar, he has already discussed about the investigations. But before investigations, actually history is more important in day-to-day practice. When we learn in our medical career, when we enter in second MBBS for clinical studies, that time we are supposed to take the history of the patient. And all of us know that history is not only the patient when he is telling that time. It is all complete history. That means we have to take a history of present illness, you have to ask him chief complaints, you have to ask his past history, you have to ask his personal history. Because all these histories, which when we take it, because it is going to take us to the provisional diagnosis of the patient. And ultimately it is the investigations which are going to take us to the final diagnosis. So before investigations, history comes. And if you lack in history, it is very difficult for us to reach the final diagnosis. So before going for investigations, detailed history taking is also very important. I will go through the slides first because I have got a very little time. As already discussed, as we know, the doctor-patient relationship in our country has undergone a sea change in last decade as such. Previously, doctors were treated as a god and they were respected like anything in the society. But nowadays, people come with the suspicion to the doctor. Why this? Actually, we also must introspect and find out the solution for that. There are 3 C's which are more responsible for this doctor-patient relationship nowadays. One is CPA, Consumer Protection Act, which has come since last 10-15 years. Then consumer awareness. Then commercialization has changed the scenario. And all these 3 C has adverse effects on doctor-patient relationship. And that is the most important thing where the judiciary comes in picture. Actually, if we have got a good communication, if we have got a good convincing power, and if we give a sufficient time to the patient, it is very less likely for us to get the complication, our relations to be spoiled with the patient. And here it is common observation that medical practitioners and hospitals are attacked by the family members or patient for alleged medical negligence. This is section 304A of IPC is sword hanging on the doctors. Basically because it is a threatening call for all the doctors. If anything happens in the hospital, there are chances that you may be put under this section and you may be arrested. But nowadays, just few days back, Maharashtra government has come out with the law that you cannot arrest the doctor unless you have got a sufficient evidence. Doctors are considered as soft targets because we don't get indulged in bad practices. And we are supposed to be the soft people, we talk softly, and we behave by law in the society. So we are supposed to be the soft targets for the social elements, antisocial elements. Allegations of rashness or negligence are often raised against doctors by persons without adequate medical knowledge. When the patient is brought to the hospital, some relative who is present that time is not present when the patient becomes serious. And that is the main problem where it is creating a complications. When the patient is admitted, some relative is present, that relative is not there when the patient, after 3-4 days when he becomes serious. There actually the problem comes. We have not convinced that particular person who has come the late. And it is very difficult for us to convince each and every person who is attending the patient. This results in a serious embarrassment and harassment of doctors who are forced to seek bail to escape the arrest. The public awareness of medical negligence in India is growing day by day. Hospital managements are increasingly facing the complaints regarding the facilities, that is infrastructure, standards of professional competence, and the appropriateness of their therapeutic and diagnostic methods. As already just in previous session, when you do an investigation, patients are always doubtful about you, whether this investigation is really required or is not required. They are, suppose the patient, as Dr. Khobragade just said, if the patient you advise second time, suppose CT scan, if the patient comes to you immediately to the hospital, CT scan is normal. And after 2, 3, 4, 5 hours, if you advise him again, and unless you do that, you are not able to find out if the patient has got bleed or infarct. If bleed, you can see immediately, but in fact, to come on the CT scan, it takes 5 to 6 hours. So when you advise CT scan again, that it creates doubt among the patients and their relatives. Why this investigation is again advised? So, what is the main important ABC, how to deal with the patient is awareness of the negligency, build strong structure process, and most important thing is communication. I think this C has got the most important thing. Here, what we see good number of patients, 15, 20, 30 patients, admitted patients. We don't have time to communicate with the relatives. And that is the main problem which is creating the doctor-patients. It is spoiling the relations between doctors and patients. I will suggest more you should devote a time to explain the disease to the relatives and the patient. And I think if you explain it properly, it is very less likely that there is some problem in your hospital. The documentation, just now they have said there's documentation of investigation. Similarly, documentation of history is also important. Proper documentation is the most important thing. And then the attitude of viewers. Then what is the case history? Just I have discussed. It is a classic form of documentation, ranges from a clinical sketches of highly detailed and extended accounts that help in arriving at diagnosis and formulation of treatment plan of a person before treatment. What are the steps? Assemble all the available facts gathered from the chief complaints, medical history, dental history, diagnostic tests, and investigation. History depends from person to person. Suppose female patient comes to you, the important thing is obstetric history is very important, or menstrual history is also important, in spite of taking other history records as well. Then the pediatric patient comes to you, you have to take the history in details from relatives. That also is very important. Analyze and interpret the assembled clues to reach the provisional diagnosis, make a differential diagnosis of all possible complications, and select a closest possible choice amongst final diagnosis. So what are the medical legal issues in history taking? Is most important thing is prescription. When patient comes to you, you must ask his previous prescription and OPD cards, what treatment he has got undergone, what procedures he has got undergone, and what consultations previously he has taken. You must be very vigilant if the patient is treated by quack. So these are the cases which has been approached in the court, and it has been seen in this particular case, which was, I think it was 2007 case. In this case, the doctors had stated a defense that a midwife had already attempted abortion, and when problem arose, the patient approached them for an immediate abortion. This defense was rejected to the court as there was no evidence on record to prove this, and even the prescription did not mention such a history. Means on the records, they have not mentioned that particular person who was treating her. She has not mentioned that this patient had been to quack, and it created problem for him. Note specifically mistakes of the patient and record time correctly in medical records. This is also very important. This I am trying to explain in the case laws. Here in this case, about 6 hours after rupture of the membrane and watery vaginal discharge, the patient was brought to the hospital for delivery. late, that means 5 to 6 hours. And these facts, which were clearly recorded in the medical records, proved to be a valuable defense in the hospital favor. That means when the patient was brought to the hospital, that time they have recorded the time, and that the history she had given was 5 to 6 hours back. So it helped for this particular doctor to as a defense, and he has been court. Elicit and record the complete, correct and relevant history of the patient. Patient's history to be duly recorded while treating. Write the history, give printed questionnaire. If possible, if you do have a printed questionnaire in your consulting room, you can give that to the patient and ask him to write in his own handwriting about his detailed clinical history or his familial history, his personal history and all these things. In this case, the patient had not disclosed that he had taken a treatment for cardiac and urinary renal problem at various hospitals about a year back. The patient underwent a septoplasty and suffered a cardiorespiratory arrest. The court did not hold the ENT surgeon liable to the patient's non-disclosure. So this is very important. In this case, the court accepted the defense that the patient had not disclosed the history of genetic bleeding disorder thanks to a very specific note made by that particular hospital where the patient was transferred, from where it was transferred to that particular nursing home. Making the patient write his or her history is therefore very important. If the patient willfully chooses to withhold information from the physician is not liable for medical negligence. But failure to record the requisite patient-related information is a negligence. Here, this is one case law. In this case, the court draws adverse interference from the fact that although the gynecologists know that the patient's first child was not normal one, and there was a chance that the fetus could be having a congenital anomaly, yet he noted nothing in the patient's obstetric history regarding the previous child, except recording the age of the first child as 6.5 years. So it created problems for him. Then second, this record specifically lifestyle habits. That we know that personal history is very important in all patients because there are so many reasons. Suppose patient is smoker, alcoholic, all these things are going to give a different diseases. So in this case, the court had held the patient's habit of heavy smoking and caused post-operative complications that led to multiple organ dysfunctions and ultimately death of the patient. In this case, the fact that the patient was alcoholic was specifically recorded in the medical records, and this fact was taken into account by the court while holding the hospital was not negligent. Record briefly the patient's history in the prescription too. Means when we write a prescription, on right side you can write on the important points of history. In this case, the defense that a local DI had already performed MTP before the patient consulted the doctor and was rejected by the court as this was not mentioned in the patient's prescription. It was not mentioned in the...
So last 1 minute, please,
yes,
wind up.
Last 1 or 2 seconds. Report of the investigation done by the patient earlier must be listed upon, and the important observation from the same must be briefly recorded in the history. Then record the name of the hospitals and doctors where she has consulted previously and whether they have taken the treatment. Record specifically whether the patient changes history during the course of the treatment and if it is discovered to be untrue. Perform requisite investigation, just already we have discussed. Record specifically the incorrect history or any important facts related by the patient and discovered. Elicit specific information from allergies, which is very important in all the patients, and ensure the admissions from where these suitable spaces of denote whether the patient had earlier consulted or admitted in the history. Record specifically the age of the patient in medical records. Record the time gap between the two admissions, successive admission. That is also very important. Thank you.
Thank you very much. I'm going to ask the honorable speakers now to basically focus on what changes you request in the law as you see it today. Special support required from the advocates. I'm going to request Advocate Mayank Shirsagar to kindly come up and give a good brief 3 to 4 minute presentation discussion on what do you feel will help the doctors to do better. Where do you think the law needs amendment?
Good morning, everybody. I would like to first give a brief introduction from where the medical negligence law has evolved. As my colleague had previously pointed out, Bolam's law. Bolam's law is a British case which was tried by common law courts, whereby the facts were a person went to a hospital known as Frian Hospital, where he was advised a shock treatment. During his treatment, he was not given muscle relaxant, he was neither restrained, and as a result, he suffered injuries during the treatment. Even fractures were suffered. at that point of time, the court came up with a particular test, that is a test of respectable minority of doctors. That is, when the court put it to test, a respectable minority agreed to the situation that these two things were not required, hence the hospital was held as not liable for medical negligence. This is where the history of medical negligence is traced. And after this, there is a judgment of Bryan, where in Bryan's case, what has happened was, the court has held that the doctors are presumed to be in a position where whatever they will advise, the patient has to take it. So it is the duty, a higher responsibility of doctors to record a proper history and then proceed with the investigation and then move ahead with the treatment of the patient. Hence, what we are here now is what is the role of doctors in taking history, which is pretty much important. As sir has pointed out, lot of cases where apart from the practical scenario, there are various cases where the history of the patient changes. At the point of time when a patient is admitted, he denies that he had diabetes. And later on, he says that, yes, I had diabetes. But when, in such a case, when all these recordings are done properly, all this data has been recorded on the sheets properly, the court has said the doctors are not negligent. The courts are there to protect all the doctors. The courts are there to protect all the doctors and the fraternity, provided the documentation is perfect, provided all the history is recorded perfectly, and a respectable minority of doctors agree to it. Because in court of law, who will testify against a doctor will be a doctor who will be called as an expert, and he will be asked an opinion as to what is the course of treatment, what is the history, what is the investigation ordered, what was the investigation suggested, whether it was correct or not. It will be one of your colleagues, it will be one amongst you who will be called. So the only way to get out of it is, it should be supported by some material, it should be supported by some cases which have been decided previously, it should be supported by a general opinion of a respectable minority of doctors. Even if, for instance, there are only 3 doctors who practice cardiology in a very small village. If 2 of them agree to a particular procedure for that village and a general minority of doctors agree, that is the test. And that is where you have to stick. And this is how you can get out of it if the history is recorded properly and a particular set agrees to it. Since I have a very shoestring time, I would like to wind up this now.
Thank you. So once again, I come to the moot point. I don't think there is any debate on the fact that history eliciting is absolutely critical, and documentation of appropriate history, however cruel it may sound to the patient and the patient's social circumstances or the payer circumstances in terms of insurance, etc. I think we need to be very vigilant and focused on this. I'm going to invite Dr. Mahesh Baldwa to please give his comments. Dr. Baldwa is a pediatrician and a PhD in law and a medical legal specialist. Dr. Baldwa, please.
You can put it. Initially, I thought that I will put a presentation, but I think my predecessor colleagues, they have given a lot of information, so I might skip through that. Now, what doctors particularly, they think and record, there is a tendency of generally of all the doctors, they initially whatever they record is the final history. There is no history coming out, but then believe me, it's an ongoing process. Each day, every meeting, if it is patient is admitted or not admitted, every time the patient comes, he brings in some information which you might have missed. That needs to be recorded. So many times we also tend to miss the comorbidities. They may sound simple. Initially, even the patients, they don't come out till some investigations come. They are surprised in the urine if they find a sugar or maybe ketone. Then they tell, I have fasted or I am having diabetes. This comes up later on. So many times the child is there in hospital being treated for encephalitis. No one comes up with a history of dog bite. And suddenly someone tells he was bitten by a dog or cat or whatever. So many times the doctors tend to consider whatever we record on the front sheet, that is the history, and that is being taken as law courts as the history. And later on, the progress reports, so many times we miss the main diagnosis or main point also there. And it might be even missed in giving a final diagnosis, or it might be missed even in the discharge card. Your history taking H. Now anyway, since I had planned for this, and I believe you will give me a minute.
I'll give you exactly a minute and a half, sir. 50% more.
History. So you can see it. So again the point is, to whatever information you have, you should record. It should be systematic. Now this should not be the position. The ears are the best thing, but not through the stethoscope. This is the case which I have described. Dog bite history was given later on. Here the old villager was knowing he is having diabetes, but no one bothered to elicit the history of diabetes. Patient when developed post-operatively infection, then the doctors in the court of law came up with that since he is having diabetes, he is prone. Now in this particular case, the history of allergy to penicillin was done. This is not our case, this is from Malaysia. And when you don't know history, so many times in some certain emergencies you are indecisive. You are cold like a frog and you don't take any action, and that's what it happened, and the patient died here. In this, Maltiben, she took the history. She knew patient is allergic. Patient is not allergic, and she did give a test. The streptopenicillin was injected, anaphylactic shock, CPR, everything was done. She was prosecuted by the lower court, the judicial magistrate first class, and later for 4 days and some fine, which was reversed by Gujarat High Court, saying everything is being done and recorded. So no negligence. This is a typical case, where typical history of fever with chills, as per the protocol as per the history protocol, one would diagnose or think of malaria, but the history of sulfur allergy was not taken. MLR, that is sulfadoxine, pyrimethamine was given. Patient developed Steven-Johnson syndrome, full-blown later on with dry eyes. So here, basically, some protocols were violated. That patient was not given chloroquine, which is a standard regime. Instead, patient was given sulfadoxine, pyrimethamine as a shortcut and for. So many times, our empirical algorithm in our mind, that does not work. And so many times, whenever we submit a literature, it shows in the same page, higher up, that this is the protocol and the next protocol is this, and we have followed the next protocol. We realize later on. Here, 2 lakhs were awarded. In this, the psychiatrist did not take the history of suicidal tendencies and could not give the order to the nurse, and patient was run over and got into accident. So please, you should not be ask if someone else has taken it, now you tell me what is the. Thank you. And
Thank you, Dr. Balbo. I'm going to request Dr. Atul Shah to come up. Dr. Atul Kumar Shah is an LLM in law, and he is a practicing surgeon. He is General Secretary of Association of Plastic Surgeons of India and the President of the Indian Medical Association, Vadodara. Old friend of mine, Dr. Atul Shah, please. Dr. Atul Shah, 2 minutes. 2 minutes. We have a whole day to go ahead and we need to be crisp. Let's focus on what you really feel is relevant to this audience. What do we need to tell the health minister and the law minister to change in the law of this country? That is what we need to focus on, sirs.
Parag, you are a CEO of a hospital.
Yes, sir.
So am I. And every other day, a junior resident comes up and tells us that this patient confirms that he has diabetes or hypertension, but he wants us not to write in the history because our histories are now becoming TPA driven or Mediclaim driven. Not diabetes or hypertension, even HIV positivity, they want us not to mention in the
So
history.
I'm going to take 5 seconds here. Sometimes what happens after the plasty is done, we realize that there is diabetes mellitus. And after our money is already sunk in terms of the cost. So then we have no option sometimes but to look at the history in a very circumspect way and decide, do we want to, do we not want to, because otherwise we are going to get rejection and neither is the patient going to pay. I think this all CEOs face, right, Atul?
So I don't know, like they have two accounts, one for C. The other thing is now we have influx of medical officers who have studied in Philippines, Ukraine, Russia, and I don't know what all countries. And their level of understanding medicine is much different than how we were taught history taking. So a junior or senior consultant is really at a task to go through the history that is written down by these medical officers and then go on adding the points. No doctor would ever miss eliciting history. But the problem is all sorts of social influxes which keep coming. And therefore, several of us have made it a point to get signature of patient and relative both when we first finish writing the initial history, whether it is in ER or it is at the first site of interview, that what all they have disclosed is what they have to disclose. And sometimes probably that is what will help on the legal platform. Thank you.
Thank you very much. May I request Dr. Jairam, Dean, Bombay Hospital, to please come up. Dr. Jairam, your comments, please.
Good morning, everybody, and thanking the Law Association as well as USV for having called me. Please give me a few minutes, otherwise it's impossible to keep your thoughts in front of people. I want to be a little bold. I want to say, legal cannot help you as much as you think it can. Only you can help yourself. We are in a profession where history taking is not for the sake of whether you satisfy the law. History taking is for treating a patient. A patient must be treated as an individual who requires your help, even probably to save his life. You are under scrutiny by the patient from the time he comes to see you, and he should be under scrutiny when you see him. Your mannerisms, your behavior, your way of asking questions, your involvement, your commitment, your sincerity should be shown. You should become that. You should not put it on. For that, you need to really get into the service. If you don't have time, please refuse the patient. When you're practicing for 2 hours and you entertain 25 patients, you're bound to get into trouble. Why do you want to entertain 25 patients if you don't have time beyond 2 hours? You're not going to take a proper history. You must learn to take the history as history is to be taken. Each and every point must be written. The patient must get a feeling that you are being considerate to him at all times. He is always right. You shall not lose your temper. You shall not talk to him rudely, unnecessarily, even if you are right. He is under a psychological stress. He treats you as a person who is going to cure you. He has already put you on a high pedestal. So I do not know why we have to be arrogant. Why we have to talk in a manner which gives them an impression that this doctor is not for me. And if by chance there are problems which will creep up as a result of treating him later on, he is bound to add on all this against you and try and go against you. So that's very important. When he comes to the hospital particularly, see that you have his entire record of previous admissions, previous illness. Even when you take history, record all that. Please record all that. Let a gynecologist aspect be totally done for a patient who is a female. Involve your colleagues or a specialist as soon as you can. We say that the nursing homes and the hospitals are under fire. But do we realize that when a serious patient comes, we don't see him for about 15 minutes, we are chatting. We doctors sometimes sit and chat in the CMO's office. And the patient outside is able to find that out. Because he sees there is no patient coming out before you're called in. Do we consider that? Why should we not immediately attend to the patient when the patient is serious? I was in a very busy consultant's room the other day. He was telling me, I know that that person is breathless, but why should I call him when his appointment is 5th? I will have to first see the first 4 patients. Wrong attitude. totally wrong attitude. I'm not worried whether it goes legally or doesn't go legally. But do we accept that as something which is humane? That's what you people have to consider, at least the medical profession here. So therefore, I would say call that patient first. I'll tell you, you will be applauded by the other 4 patients who has the appointment before him. They will realize that this is the message you're sending to the patients. So therefore, I think this is very important. So far as taking history is concerned, I do not think there are any legal amendments which are going to help you. What is the legal amendment that you can have so far as history taking is concerned? If you're going to note down each and every point, if you're going to be frank with your patients and discuss with them that this is the present situation, this is what I can do. Despite doing this, the patient is likely to have this complication. These are the other doctors available with me in this hospital. If I think 1 or 2 of them can be useful to me, I will involve them. I will see to it that we'll give you the best service. But despite the best services, still we may be found shorting because after all, we are human beings. We are not God. Send this message. Be kind to them, as Dr. Dagankar said, communicate. Communicate. You know the patient is serious. You know the patient is going to die. You know it's 2 o'clock in the night. Everything is fine. But there are a few relatives who are agitated. Why not go there? How many times have we to go there in a term of a year? 2 days, 3 days, 4 times. Go there, talk to them, pat them, be with them, be emotionally involved, see the response. Nobody will go to the court. Interpretation of an honorable judge does not depend on what your lawyer says or what thing is. His interpretation is entirely what he thinks is negligent. And he may not be wrong. The lawyers, of course, help you. Now, a patient was discharged because he slapped a nurse. This patient was extremely bad. He did take treatment after that in other hospitals. He died 1.5 years later. The honorable judge has found it fit to slap strictures against the doctor who discharged this patient because this patient slapped a nurse, which was 2 years before this. He says this is negligence. He says you did not give him the discharge paper. He says you did not treat him properly. He says you did not advise him what he needs to do. Now, where is the lapse? Where is the medical problem? Where have we not treated the patient? Patient died on his own accord, but did we behave well? So, ladies and gentlemen, I'm sorry, I've already taken a lot of time. My only point is, don't worry about what laws are made. Don't worry about what people can do for you. I know our lawyers are very helpful to us. I know our judges are very sympathetic. They are extremely sympathetic, let me tell you that. But let me tell you one more thing, and that is the most essential thing. You can only protect yourself. And the only way you'll protect yourself is if you first realize that you are there to save and benefit the mankind, and therefore you will do whatever it is required to help them and to see that you save them. Forget the law, forget everything else. Be humane, it'll help you.
Thank you, Dr. Jairam. Thank you so much. I'm going to wind up, and I'm going to request Dr. Rahul Vani, gynecologist and law graduate, to take exactly 1 minute. Dr. Vani, I'm sorry, you're the last, which does not mean you're the least. I'm sure you have something critical and important to say on the art of taking history.
As Sir has already emphasized the importance of history taking and cannot be amended by law, I have nothing more to say. But as a medico-legal aspect of history taking, I would point out some important things which need to be recorded. Like if the patient has concealed the history and later on it comes to your notice, it is to be recorded that the patient had concealed the history so that it can protect you if the things go wrong. If the patient has taken treatment from a quack or an incompetent person before, you have to record it so that if the patient lands up in complications, then that can protect you. Especially in today's scenario when MTP pills are given on over the counter and the patient lands up with anemia and septicemia. So if you have recorded that the patient had taken pills from a chemist or from a BMS or BHMS doctor and was unsupervised, this will help you. Sometimes the patients are notorious, as Dr. Atul Shah was saying, that for insurance purpose they give a different name, and on birth record they want a different name. I think we should not indulge into all this. Whatever is the history and whatever they have said and whatever is the actual name, we should stick to that. For adoption purposes, they ask you to change the name. So they want to give that child to one of their relatives without going through the adoption process. All this should be avoided. Thank you.
Thank you, Dr. Vani. Thank you very much. That was really crisp. I think Dr. Vani's kind of summed it up pretty well. All of us are clear that taking history is important. To Dr. Jairam's point of OPD patients, NABH is, in its 4th edition is also introducing a standard of triaging of OPD patients, because sometimes OPD patients come to OPD with emergencies. I think the whole world is now moving towards evidence-based medicine, where safety of patients is paramount, safety of personnel is paramount. And I think we're going to open it up for exactly 5 questions, comments, discussion points, because I already see my colleagues from the hospital discussion trickling in. So, sir, I'm going to give it here. Dr. Balwa, you had a chance. Sir, please. I'm sorry, sir. Sir, we are always wanting to say more, I'm sure. We'll discuss it over lunch, sir. We have enough time over lunch and over tea. Sir, introduce yourself, please.
I'm Dr.
Sir, you're audible.
I'm Dr. Sanjay Das. I'm a professor of forensic medicine at Dehradun. Mine is not exactly a question. I listened to so many speakers now. Dr. Baldwin and Dr. Jain just spoke about communication, attitudes and all. My friends in the MCI also would agree things would go better definitely. They are coming up with the ATCOM module, the attitude and communication module for teaching medicine, and also the competency-based medical education. I think that would go a long way if you can actually be with them.
Absolutely.
Thank you.
Absolutely. Thank you. Sir, gentleman in the suit.
Oh, very good morning. I am Dr. Surya Prakash from Chennai. I am representing the dental fraternity. First, because of the history, the main problem what we face is when a patient comes to dentistry, when we ask for the history, the patient feel why we have to tell all this to this fellow. So it is like they hide many of the things, and because of that, we face many problems. So by this conference, if we're going to push on the health ministry to DCI to form a clear structure of how to proceed with history. Because if I am asking for one investigation, the patient goes to next dentist and he doesn't ask, and he gets the treatment and goes. And he tells it everywhere that this dentist is asking for too much of money and investigation. So we should have a structures protocol for the history so that we follow the entire thing, and we should force the DCI to form Indian guidelines, and where we, most of the dental, I don't know about medicine fraternity, but dental fraternity, we are just following what is there in the West. We don't have Indian guidelines. So we should force the DCI to create an Indian guideline so that that will be useful for the people welfare.
Point taken, sir. Point taken. I think this is a matter for professional bodies to indulge themselves. I think over and above presenting scientific papers, some focus has to go there. Sir, over there, please. And we're going to take the last question from...
Good morning. I'm Dr. Mudassir from Mysore Medical College. I'm from community medicine, public health. So since you said about the health ministry and the recommendations would be put forward to them, why don't we start a system similar to in UK, where the GP system, where they refer the cases only when necessary, and they have an area where under the purview of that area you are, it's mandatory that you report to that particular general practitioner.
Dr. Mudassir, I am going to cut you short. I'm very sorry. We are not going to today discuss the overhauling of the Indian healthcare system. There are a lot of commercial gains, deals happening within the system. Let's leave the entire rehauling. I don't think even the government medical system is working in the way it is supposed to, despite the fact that it is envisaged to work exactly how you say, wherein you have a primary health center falling into the CHC, into the district hospital, and so on and so forth. So I don't think that's going to be possible. I thank you for your time, and I'm going to request the mic to be handed over here, sir. And that's the last question we'll be taking, and then we'll be breaking for exactly a crisp 10-minute networking break. Sir.
Wherever there is a medical legal dispute in a court, generally a medical expert is called for the opinion. And we find that a medical legal dispute against a private practitioner, the medical legal expert is practicing in an institute or in a bigger hospital. And he gives the opinion according to his practice in a bigger institute. So there is always a private practitioner coming into problem.
Sir, this has nothing to do with taking history, and hence I'm not going to entertain that as a comment right now, for the sole reason that history taking is common and should be the same to to all patients, whether you're in a government hospital or a private hospital setup. So to kind of sum up, all of us agreed, and I think Dr. Jairam epitomized everybody's thoughts very well when he said that a good history eliciting is the patient's right. If you don't have time to elicit patient's history appropriately, don't take on that many patients. There is nothing, we all agreed, in the law that really needs amendment. I think it's the doctor's sort of, what should I say, behavioral aspects that at some stage might need to undergo some sort of change, in the sense that we need to focus. If we are going to see 30 patients an hour, then we see to it that we have a battery of 5 other junior doctors sitting with us, equally qualified, and we have a system of doing things in such a way that the final outcome, the clinical outcome, is impacted by everything that is required for that particular patient's history to be taken into account. One other comment, which something that did not come up, is that we become so super specialized in our pathies that we don't elicit history of other organs and systems which actually are relevant to the problem on hand. Sometimes you have a systemic problem, you're looking at only pain in a particular area. That is something which we don't elicit. So systemic examination, systemic history eliciting, comorbid history eliciting is something that we all agree must be taken. With that, I'm going to declare this session closed. We do have a timeline to run. With the permission of the organizers, it is exactly 12:05, and I'm going to reconvene at 12:15 with the next session, that is providing free treatment, medicine, bed, food to acid attack victims. Thank you very much, ladies and gentlemen, for all the constructive role that you played in these two discussions.